everyone. Thanks for coming to my talk today. I'm titling this Hot Topics in OB, or using evidence-based practice. And really our goal is to look at what's happening out in the practice world, labor and delivery world, and see how we can apply the current evidence to help improve our outcomes. So let's get started. Our objectives today, we're going to analyze the common practices that we see in our OB units. We're going to review some of our current trends, discuss best practices based on the evidence. And at the end of this presentation, the student learner will distinguish techniques to decrease the incidence of cesarean section in the low-risk population, which is commonly called the NTSV, nulliparous term singleton vertex, and plan some methods of implementation on your own unit. So I'm hoping you'll have some takeaways that you can take back to your units for further discussion. This video will also be available to you so that you can share the URL with your coworkers and colleagues and maybe have a conversation. So my goals of bringing this information to you today are to present the current evidence. And most of what I'm bringing to you today is from the work of AWAN, from the work of CMQCC, and from the work of Rebecca Decker, PhD. I am hoping to encourage some conversations with bedside champions and spark the curiosity to continue learning about these subjects. So my hope is that this is going to be a start of a conversation with each other, with policymakers, those of you that are writing the policies for your units, perinatal safety coordinators, managers, directors, bedside nurses that are bringing this practice to the actual bedside, educators that are teaching our new generation of nurses about this specialty, and of course, providers, anyone that is providing care to women in the maternal child health setting. So I encourage you, I wholeheartedly encourage you to be a change agent. There's something called the evidence practice gap. And what this is we know the evidence, we've seen the research, we know the best practices, and then we have what we're doing at the bedside. And then there's this gap in between those two. So for instance, some of the things I'm going to talk about today are practices that we've been using since the 1950s. Even though we know the evidence is out there to improve these things, we haven't been able to make that change at the bedside. So that evidence practice gap can be somewhere between 18 and 20 years, meaning we know the evidence is there, and now we're 20 years later at the bedside still doing the old practice. So sometimes you'll hear people say, well, we just do that just because that's the way I was taught. This is the way we always do things. The old way works. These are phrases that you'll often hear people say. And I implore you to be a change agent. And I'm going to give you some ideas at the end of this talk about what you can do. Some of the threats that we see to our high quality maternity care: hospitals and healthcare systems prioritizing cost and convenience or provider preference over what's best for moms and babies; perinatal services, failure to have policies, procedures, and protocols based on national standards; and clinicians, that's us, failure to keep up with the evidence, standards, guidelines specific to our area. How do we stay up on this evidence? I'm going to have some ideas for you a little bit later. Disruptive, unprofessional behavior. In my practice, I talk a lot about how incivility among nurses affects patient care and patient safety. It's a huge problem. Nurses eating their young is not okay. And we need to move past that and bring the evidence to the bedside. And then not respecting women's choices, not respecting the autonomy that comes with having a baby. Remember, these women have chosen us to care for them. They use their medical dollars from their insurance companies. They choose where they're going to bring those dollars. And so really we are service oriented in that women come to us and are making decisions to come to us, and we need to respect that they have the right to refuse the suggestions that we have. And I'm going to go into that more in just a minute. So where do we stand? Let's look at where we are in our current statistics. Well, this graph here looks at the maternal mortality in the United States. In all the rest of the world, and let's see, we can't see the numbers here, but in all the rest of the world, since about, this is 2006 here, maternal mortality is declining. Portugal, Germany, France, Canada, Netherlands, Spain, Australia, Ireland, Sweden, Italy, and Denmark, maternal mortality is declining. But in the United States, this is the United States line, it is actually rising. Here are some more trends that look at the United States specifically and related to pregnancy-related mortality. So this is surrounding the 3 months around giving birth. And you can see that steadily we have been on a rise. Here are the causes. Currently, the #1 cause of pregnancy-related death, and these charts are about the most current we have. I took these right off the CDC website this week. Our current biggest issue is other cardiovascular conditions, and that is the #1 reason for maternal death. We also have infection and sepsis, cardiomyopathy, and hemorrhage. And just recently, hemorrhage was the #1 reason, but we were able to adapt a protocol, the A1's hemorrhage protocol, postpartum hemorrhage protocol, and we've been able to decrease that by using evidence-based practice. That's what evidence-based practice helps us do, is change these outcomes for women. And then looking at it by race and ethnicity, and I'm sure you've heard about this. It's been talked about quite a bit in the last, I'd say 6 months to a year. Excuse me. And if you are of color, you have 4 times the rate of mortality around childbirth than you do if you are not of color. And now let's look at cesarean sections. Looking at the world, the United States is one of the highest rates of cesarean section. So looking at the cesarean section rates, you can see the United States is one of the highest countries. Depending on where you live in the United States, will increase your risk of having a cesarean section. And we're talking about cesarean sections, first-time moms, as well as repeat cesarean sections. And according to the CDC, this comes right out of the QMCC network here, the number of cesarean sections in the United States has increased 60% in the years 1996 to 2009. And there have been no demonstrable improved outcomes for moms and babies. So we have increased a major abdominal surgery in that time period. And there have been no improved outcomes for moms and babies. So they go on to say, the overuse of this major surgical procedure has significant social, economic, health costs, including higher rates of maternal complications and longer recovery times, and that includes postpartum hemorrhage, higher rates of NICU admissions, and increased barriers to the mother-infant breastfeeding relationships. So that's where we stand with our statistics. So with all of these things, you would think, looking at the cost of our childcare, looking at where we stand in the world, how much does it cost to actually have a baby in the United States to get those kinds of outcomes? We're also the most expensive country in the world. And for fun, I thought I would review this. Here we have the next potential King of England, and with her maternity care, where she had private care, she had a wine list with her meals. She had a very unique situation. It still costs less than it does to have a baby in the United States. It was just for fun. We'll put that in there. Okay. So as bedside practitioners, what's in our control? Can we control the costs? Can we control these outcomes? Can we make a difference at the bedside? Let's take a look. So here are some of the things that we as bedside practitioners can actually control. One of the things is we can stay current. How do you stay current on what is the best possible outcome? Not every bedside practitioner is going to spend their days off reading every journal, comparing the literature, looking at the outcomes, leveling the research that's out there to determine if the study was done well or not. But there's a place, a magical place that's done all this for you. A1, this is our professional organization, Association Women's Health, Obstetric, and Neonatal Nurses. They take all of this information and provide it to us in a magazine, in a journal, and our membership supports this. A lot of the research that I've used today for this talk actually comes from the 2 most recent books that were published by A1. So I absolutely implore you, if you work in labor and delivery, if you work in maternal child health, please become a member of A1. It is completely worth it just to stay current. Look at the resources I provided today. I've given you a whole list of resources at the end of this talk. I have pointed you to several different places, and that will help you stay current on what the evidence-based practice is. And initiate conversations with other clinicians. How many times do we sit in our units and just talk about the weather or other things when we could be initiating conversations about what we're doing in our work? I have learned so much just from talking to women, to women and men on the units and thinking about their experiences and learning from their experiences. And when someone goes to a conference, having them bring that information back and sharing snippets of it with our colleagues. There's so many ways that we can increase our knowledge base just by talking to our colleagues. So here we're going to review some of the current practices versus best practice. And all of this I have provided research for. Everything in this talk today is not my opinion. It is all has evidence to back it up. So one of the things that we see is our current practice of our failure to progress diagnosis. In fact, in the readings that I was doing, that's the #1 reason for our primary cesarean sections nowadays is a failure to progress. And we're going to look at what the evidence is and what the best practice is when we are determining if somebody is not progressing in their labor. Another part of that is looking at how the labor curves, our Friedman's curve that we have based so many things on, practice from the 1950s, really was looking at how women were giving birth in that time, and it doesn't apply to how women are giving birth in today's day, 50, 70 years later. So we're going to look at, when does active labor actually start? Our practice of not feeding women in labor. Women in labor are running a marathon, whether they feel it or not. If they're using an epidural, they are running a marathon. If you're running a marathon, do you need fluids? Do you need food? Do you need something to help keep you going? You do. And so looking at the best practice of feeding women in labor, and then our IV fluids. We constantly have our practice is to have everyone on an IV. Is that really necessary? What does the evidence say? We're going to look at that. And then I'm kind of covering this part, but laboring in bed. That's a current practice in a lot of our areas. And we know best practice is walking, upright positioning, using aids like peanut balls and birth balls, using techniques like the spinning babies technique. If you haven't taken a spinning babies class yet, I highly recommend it. I think it should be standard required practice for every labor and delivery nurse to understand those techniques. And then continuous electronic fetal monitoring. That is something that we're probably not going to move away from because of the legality of it. But there's good options for telemetry fetal monitoring, which will not interfere with the woman's ability to be up and moving around, and we can still see the baby at the same time. So let's review each of these. Oh, a few more here. Valsalva or purple pushing. We're going to look at that, what our current practice is. Hold your breath, count to 10, do it again. Hold your breath, count to 10, hold your breath, count to 10. Let's look at what the evidence says about that. And then staffing and elective inductions. I'm not going to go too deeply into these, but these are conversation starters. Remember, my goal here is to spark conversation. I know it was all fun and games until I got to staffing, but looking at safe staffing based on staffing standards that have been created by our professional organizations, we need to be following those. Those were created to increase safety for our patients. And if we're not following those, we are not increasing safety for our patients. And I know there's a lot of back work that goes into that. That's a big conversation. That's really a topic for another talk, but a conversation starter. And then elective inductions based on provider preference. So we're going to spend a lot of time looking at informed consent and shared decision-making. These are kind of buzzwords, buzz phrases that we have seen and heard quite a bit about, but let's talk about what they really mean. So here we go, looking at the evidence, shared decision-making and informed consent. Let's break this down and unpack this a little bit. So shared decision-making has been described as a collaborative process that acknowledges the patient's authority in healthcare decisions, not my words. A clinician has a responsibility to fulfill their duty by making available their complete knowledge based on evidence and expertise to the patient. And then we have to give the patient the opportunity to receive that information and then support their decision, which may include not following through on the recommendations that we have. So shared decision-making is allowing the patient to have the information based on evidence and based on our experience. We give them that information, tell them for their specific circumstance why this makes sense or why this doesn't make sense, and then we allow them to make that decision. For instance, when we talk about eating and drinking in labor, we can tell them what the evidence is. We can tell them why the policies are written. We can tell them about a very, very, very small chance of aspiration if they have general anesthesia, and then let them make the decision if they want to continue taking fluids or eating lightly. So shared decision-making is allowing the patient to have autonomy in their care. Remember, for the most part, when you're having a baby, you're not ill. It's not like you broke your leg or need a surgery to fix something or have an infection. We're talking about the low-risk mom that comes in to deliver her baby in the place that she has deemed the safest place possible, with the people surrounding her that she has chosen. She's chosen us to care for her, and we're offering our suggestions and then accepting what her decisions are. That's shared decision-making. And then when we move into informed consent, it goes along with shared decision-making. We're talking about the risk, benefit, and alternative. So let's talk about elective induction. How many women are told the risks of elective induction, increasing your cesarean section rate by 40 to 50%, or the benefit of elective induction, or the alternative to elective induction? Now, I'm not talking about women that are sick and that need their babies will be healthier on the outside, or they will be healthier with their babies on the outside. I'm talking about purely elective. Let's just do it. Let's just get this baby out. How many women are actually given or are able to make informed consent? How many women even know that it's going to be a several-day process? These are the things that we as practitioners, as clinicians, as bedside nurses need to make sure that information is available to these patients. It's not okay just to say, my doctor or your doctor recommends this. They need to be have informed consent about the risk, benefit, and alternatives. So looking at back to basics, some of the things that we really hope our moms do, this is some of the research I have done, is really encouraging childbirth education. I know it's a little bit hard to find. It doesn't look like it did 20 years ago, but there's lots of good information. We can send people to reliable resources. Things like the CDC has a ton of great information. CMQCC has a ton of great information for moms. Lamaze.com has a ton of good information for moms. A1 has good information for those practitioners. Looking at, is this an elective induction? Does she know that she has a choice? She does have a choice. Looking at the benefits and risks and promoting shared decision-making. And then we're going to break down early labor in just a few minutes. But one of the things that we as practitioners, as clinicians can do is helping them to know how to handle early labor. It's okay to do that early labor outside of a medical facility. In fact, it's preferable. If they are, remember we're talking about the low risk mom, if they are low risk and they have no other reason that they need to be in the hospital, then early labor is best done at home. And early labor can last 12 to 24 hours for some women, especially in a first-time mom. Let's look at labor length and our early labor tools. Let's break down. What does the evidence say? So the Friedman curve, which is what we really base most of our labor lengths on, was studied in 1955. What was happening in the maternity world in 1955? Well, that's when we were using scopolamine and twilight sleep. And a lot of this research was done with women that were under scopolamine and twilight sleep. So even that right there is going to change how women today are laboring, because they're not under amnesiac drugs. They're not under the influence of that. And then in 1978, Friedman looked at it again and determined what was failure to progress and when normal labor wasn't progressing. There have been significant changes, and again, not my words, significant changes in maternity care in the last 50 to 70 years. I think everyone would agree with that. One of the things that they found is that women are older, having their babies. We are able to have our babies at an older age in this period, and we have a higher body mass index than they did 50 to 70 years ago. And both of those things increase length of labor. We see oxytocin induction and epidurals, they're common, and they also contribute to longer labors. So when we look at labor dystocia, the definition of this is slow, abnormal progression of labor, and it is the leading indication for primary cesarean section, as I said before. So based on all of this data, they found that half of cesareans are done for laboring women that have not even reached 6 centimeters. They're looking at these old Friedman curves and saying, well, she's fallen off the curve. And so this is a failure to progress labor. All of this research, when you unpack all of it, it tells us that active labor really doesn't start until about 6 centimeters for most women. We don't see a rapid increase in dilation, effacement, and fetal station until about 6 centimeters. And so if we're doing half of our primary cesarean sections for failure to progress, and these women haven't even reached 6 centimeters, we aren't even giving them a chance. We need to look at each individual situation and not jump the gun and have a little patience. That's best practice. So I've given you several slides here that you can take a look at. You've got, comes from CMQCC, and these are the ranges based on the current evidence of what we should be using. And looking at some of these hour ranges, we certainly have not been following this. So it's normal. First stage is difficult to define, but it can be anywhere from 3.9 hours, which is the median duration, up to 17.7 hours. So long time for that first stage of latent labor. That's 0 to 6 centimeters. Here we're looking at 6 to 10 centimeters. And again, looking at these hour ranges, somewhere between 2 and 7 hours. It's normal to be 2 to 7 hours in that 6 to 10 centimeter range. And you can look at these. You can stop these, stop the recording and take a look at these. And then here we are looking at second stage. This is complete dilation to the birth of the baby, looking at our pushing times with epidurals and without epidurals. And again, this is based on our current population of birthing moms and not on that 70-year-old document. So here are some other ways that we can support vaginal delivery. This is just a little graph that I created. Early labor, cervix less than 6 centimeters. If mom and baby are low risk, consider sending them home. Consider sending them home and allowing them to do early labor at home. If they are admitted, then we have all of these tools to help them in early labor. Number one being ambulation, upright positioning, and freedom of movement. And freedom of movement includes things like saline locking them. We're going to unpack the idea of IV fluid for everybody in just a minute. Looking at upright positioning, getting out of that bed, using either intermittent fetal monitoring or our telemetry fetal monitoring. Using the tools that we know will help them. Peanut balls, water for pain relief, other non-pharmacological support tools like the labor nurse at the bedside. And then active labor, we are looking at 6 centimeters and above. And then if we do have an epidural, we need to be changing that position for that mom every 20 to 30 minutes. That's our job as the nurse, is getting in and moving the mom just like she would be moving if she did not have an epidural. We know that that increases the chance of the baby getting into the best position for delivery and decreases our chance of having a baby that is in a malpresentation, which lengthens both labor and delivery. And malpresentation is one of the biggest risk factors for primary cesarean section. They go together. Okay, let's unpack that eating and drinking in labor. Let's look at that evidence. So these restrictions are based on care, again, from the 1950s and the risk of aspiration and general anesthesia. Very few women in modern day labor and delivery have general anesthesia. The latest Cochrane review reports lack of evidence to support restricting fluids and food during labor. And that comes from 2013 information. So we've known since 2013 that there's not enough evidence to support restricting fluid and food during labor. But yet, most of our units still restrict fluid and food during labor. So how do we change that? We need to have good conversations with our anesthesia departments. Our perinatal safety coordinators need to look at those policies and determine what is the evidence and write those policies based on that current evidence and best practice. We know, or at that same time that that research was being done, is that the stomach is never actually completely empty, and fasting stimulates acid secretion, which increases the risk of aspiration. Women, again, using that informed consent, using the shared decision-making, we can let them know about the very small risk of aspiration related to general anesthesia and allow them to make the decision regarding oral intake. When we look at IV fluid, interestingly enough, our IV fluid rates, our 125 mLs per hour, is probably not enough to support the mom anyway, and that if she is able to drink orally, she probably will be able to fulfill her needs better than what we're doing with the 125. And what we do know is there's not enough research to justify the practice of IV fluid for every mom. Now, there are certain circumstances that we know we have to have IV fluid, but for every laboring mom that walks in that door, we don't have to start an IV right away. If she has a regular diet, there's no reason for her to be on an IV. If she is able to take fluid orally, there's no reason to additionally give her fluid in the IV space. Increased risk of infection, increased risk of fluid overload. And what we do know, the research is out there, is that the IV fluid definitely increases the swelling in the breast, which is called engorgement. And that will affect breastfeeding once the baby is born, because that fluid has to go somewhere and it does third space into those tissues. So there is not enough research. Best practice is not to give everybody IV fluid. Now, why do we do it? Because go back to those phrases. That's the way we've always done it. It works that way. It's provider preference, but we shouldn't be practicing medicine based on those things. We should be looking at the evidence and then writing our policies and protocols around that in order to support best practices for these women. Let's look at maternal movement. This is a big one. I spend a lot of time talking about maternal movement. So recumbency, again, these are not my words. Recumbency, which is laying on your back and lifting your legs up high, pulling them way back, is a Western tradition. And it was started for convenience of the obstetrician. This is around the time that birth moved from the home into the hospital. And that was for the convenience of the person that was down low catching that baby. No woman on this earth, if left to her own instinct, will lay down on her back, flat on her back, and bring her legs up to deliver her baby. That's not the natural position. Policies that encourage upright positioning, walking, result in shorter labors, more efficient contractions, greater comfort, and less need for pain medicine. Again, not my words. We know best practice is for women to be upright. We need to have policies that support that. Mobility in labor decreases the rate of operative birth by 50% and decreases fetal malpresentation, as I already mentioned. And upright positioning in labor is safe and effective and should be encouraged by perinatal nurses. And that comes from ACOG, it comes from AWAN. They have all put out position statements that say this is what we should be encouraging. So as a labor nurse, when you bring them in and admit them and hook them up to an IV and put them in bed so that you can monitor them, we are not using best practice. We need to be thinking outside of the box. And if we have to change our policies, that's what we need to do, because that's not best practice. And how long have we known this? We've known this for a very long time. And so that evidence practice gap is still there. So let's be a change agent. Let's pick one of these things and spend time on it and write policies about it. And I have more ideas about that in just a minute. So looking at how we can encourage movement, here are all the different ways that we can encourage movement during labor, different comfort measures, comfort techniques, things that we can say to this mom. As a labor and delivery nurse, we make a difference in the way that we speak to her, using the language. Instead of the doctor's coming to deliver your baby, let's think about the doctor's coming to catch your baby. The doctor's coming to support you as you deliver your baby. Just empowering her with our words can change this outcome for this mom. Let's look at Valsalva, or purple pushing. What do I mean by that? Purple pushing is known as that hold your breath, take a deep breath, hold it to 10. Why don't you all try that right now? Take a deep breath and hold it to 10 and bear down while you're doing it. And then take a deep breath and hold it to 10 again. And do that 3 or 4 times over the next minute and see how you feel afterwards. You could even lay down on your back and pull your knees up to your chest. In 2016, AWAN came out with a position statement that this practice, which I see pretty much every day in our labor and delivery units, this practice is physiologically inappropriate and outdated. We should not be using it. That's what we call coach pushing or purple pushing or Valsalva. pushing. When we do that type of pushing, we are creating a Valsalva response. And what happens when we do that? We impair our blood return to our lower extremities, and then we increase and then decrease our blood pressure, which results in a decrease in uteroplacental blood flow. And what happens when we have a decrease in uteroplacental blood flow? Well, we have a decrease of blood flow to the fetus. So now our baby is reduced oxygen capacity while we are doing this purple pushing. And so if we're asking our mom to push for 2 or 3 hours, which is what we looked at just a little while ago, that could be normal, especially with an epidural, what do we think our baby's reaction is going to be? We're going to see increase in that second stage, takes longer when you purple push, believe it or not, and a decrease in the APGAR and a decrease in umbilical cord pH. So we're decreasing our oxygen levels to our babies. Passive descent, also called laboring down when you're at the bedside, which is, there was a big study done in 2017, 2018, called the Cahill study. And lots of people like to refer to this. Now, if you look deeply into the Cahill study, it did say that laboring down increased your chance of hemorrhage and infection. But if you break that down quite a bit, I'm going to scoot over so you can see. When we look at the actual evidence for the Cahill study, the blood loss between immediate pushing versus delayed pushing was 419 milliliters versus 424 milliliters. The rate of blood transfusion was 1.2 in our immediate pushing versus 1.3 in the delayed. So there were not huge increases in these things, very small. In fact, most of them were not statistically significant. So what we do know about passive descent or laboring down or waiting for the Ferguson reflex, which is that pushing urge, is that it decreases our operative birth, it decreases our perineal injuries, and it decreases our pushing time. So again, staying current on the evidence, not just listening to a few opinions about what the research shows is super important. And so A1 has come out with the position statement, and ACOG also came out with the statement that in some circumstances, delayed pushing or laboring down may benefit women. So again, we would give the mom the information based on evidence and experience for her specific situation, and then allow her to decide what she would like to do, and then support that choice. So looking at that evidence practice gap, like I've said, our clinician responsibilities, how are we going to bridge that gap? How are we going to jump over that edge and deter and make a change in our practice? I know for a lot of us that have been at the bedside for a long time, we've worked with particular providers for a long time. We know that's just the way they do things. And some have very strong opinions on their practices because that's the way we've always done it. This way works. And those old ideas get stuck in our head. So what can we do? Let's unpack that a little bit. We can partner with patients. We have to change our mindset. They are coming to us because they respect us and they trust us and they're asking for our care, but they have choice. And if they're informed, they have the right to not do what we're recommending. So if a patient comes in and says, I don't want to labor in bed, she has the right to make that decision. If we explain to her that maybe we aren't going to be able to monitor her baby as well as if we did if they were in bed, she has the right to make that decision. Ensuring patients have enough information in a format they can understand to make a decision is the responsibility of the bedside clinician, and that comes from Simpson. She says that these are the things that are within our legal, ethical, and moral responsibility as bedside clinicians, partnering with patients, respecting autonomy, and ensuring that they have enough information to make those decisions. So let's look at what happens when we utilize some of the best practices, all the things that I've talked about here today. And I've just touched the surface. There's so many other topics that we could use as other talks, but this is just scratching the surface of some of these. So when we utilize best practice, we have increased patient safety, we have increased nurse satisfaction, and prolonged nurse retention. That's a big hot topic today. We have high quality maternity care. We're decreasing the cesarean section rate, which is decreasing the hemorrhage rate, which is decreasing the maternal mortality rate. We have decrease in healthcare costs. We have decrease in those near miss events. We have decrease in nurse burnout and moral injury, and decrease in maternal mortality. So why wouldn't we want to use best practice? Is there any reason you could think of that we wouldn't want to use best practice? No, we just have to bridge that practice gap. So here's how we're going to do it. Here are some suggestions. Pick one of these topics. Pick something that piques your interest. Start a conversation. Maybe start a conversation with the policymakers, with your colleagues, with your friends and family. Friends and family coming in, knowing that they have some autonomy and knowing that we need to respect their choices will be some of the biggest voices that help us make change. Maybe write a policy. School, this is a great school project. If you're continuing on and completing your bachelor's or master's or even doctorate, these are great projects to work on and bringing evidence to the bedside. Give a presentation. Contact us and let us know you want to give a presentation next year about one of these topics that you are passionate about. And then talk about it on your units. Spend your time on your units talking about the things that you can do to increase your patient safety and in return, increase your nurse satisfaction. The benefits of joining AWHONN, here's another plug. Right here in Kern County, we have our own AWHONN group. Right now, with everything being online, you can actually join many AWHONN groups across the country. I cannot say enough how much of a benefit that is to your professional practice. And it is each of us, it's our responsibility to build our own professional practice and stay up on that evidence. So other things that your membership will support is supporting nursing excellence, keeping the professionalism in our specialty, career advancement, collaboration, and again, try to find a local chapter. If you're not local here to Kern County, try to find a local chapter that will support you and you'll be able to collaborate with your colleagues. So what did we learn today? Well, we talked a little bit about clarifying our responsibilities as clinicians. We reviewed some of our current statistics, which are not good when you look at us compared to the rest of the world, our medical care being the most expensive medical care there is, yet having some of the poorest outcomes. It's an embarrassment. We discussed what our current practices are and compared them to what the evidence tells us is best practice. We looked at that evidence practice gap, and I hope that I was able to spark some curiosity into investigating it further. I really would love to inspire you to be a change agent. If each of us picked one topic that we could use and spend time on and teach our colleagues about and change policies about and educate our patients on, then we could change the world. And I hope I invited some open dialogue. If you'd like to further this conversation, my contact information is at the end of this presentation. Here are just a smidgen of the references and resources that I used. I would love to give you more, and my contact information is right here. So if you want to reach out, I would love to continue this conversation. If you want to talk about changing policies and what the next step would be, you want to join our local AWHONN, you can go to the Facebook group and just search AWHONN Kern County chapter. I have enjoyed presenting this to you today, and I hope we can continue the conversation. Stay curious.